Okay. Good morning, good afternoon, and good evening, everyone. Welcome and thank you for joining the Enhancing Patient Care in Ghana through Nursing Research, Quality Improvement, and Evidence-Based Practice webinar. Before we start, I would like to give a brief introduction of GDNA's mission and vision. My name is Josephine Ajay. I am the co-director of Membership and Communications of GDNA. So what is our mission? Our mission is to foster a sustainable local global collaboration between Ghanaian nurses in Ghana and the diaspora to advance nursing education in Ghana and improve health outcomes of Ghanaian people. Our vision is to significantly contribute to Ghana's ability to produce global nurses who are skilled and knowledgeable in specialty nursing areas to improve health outcomes. As part of our mission and vision, we want to emphasize the importance of utilizing nursing research, QI, and EBP to improve nursing care in Ghana and the rest of Africa. For this webinar, I would like to go ahead and introduce our two presenters. First, we have Dr. Diane Baptiste. Dr. Baptiste is an associate professor at Johns Hopkins University School of Nursing. She is a certified nurse educator whose teaching is grounded in cutting-edge, evidence-based instructional methods with a strong commitment to health equity in education, practice, and research. Her sustained scholarship focuses on cardiovascular health across the care continuum for underserved population, grounded in responding in social justice issues influencing health outcomes. Dr. Baptiste is the current editor-in-chief of Nursing Open, a peer-reviewed journal and a widely publishing company. She also serves as the principal faculty for the Johns Hopkins School of Nursing for cardiovascular and chronic care, guiding continuum education program and dissemination of research for students, faculty, and international collaborators. She is an exemplary integrated scholar who is committed to transforming patient care as well as supporting nurses of all of the future. Thank you, Dr. Baptiste. Our next presenter is Stephen Adombire. Mr. Stephen holds a Master's of Science in degree in Clinical Nursing from King's College London, United Kingdom. He is currently a PhD candidate in nursing science at the Lawrence S. Bloomberg Faculty of Nursing, University of Toronto. Stephen has worked as a registered nurse within the Ghana Health Service in rural northern Ghana, raising to the ranks of principal nursing officer, and has held various leadership roles. Stephen's academic interests include evidence-based practice, quality improvement, and implementation science. His PhD thesis has the goal of advancing nursing evidence-based practice to improve healthcare outcomes. Stephen is also the director for evidence-based practice with GDNA. Now, I would like to go ahead and hand over to our presenters. Welcome and thank you.
Thank you. Thank you, Josephine. It's really an honor and a pleasure to be here today. Before we begin this presentation, I just want to state that the presenters, Stephen and I have declared no conflicts of interest. So here are our objectives for today's talk. There are 5 objectives. The first is to appreciate national and global agenda for improving quality of care, of healthcare. Also to define the purpose of nursing inquiry in improving care. We also are going to lead you into differentiating between EBP, QI, and research. And we're going to recognize how to assemble a project team and to establish appropriate collaborations. And finally, we will help you identify ways that nurses in Ghana can effectively apply concepts of EBP, QI, and research to improve patient outcomes. Over to you, Stephen.
All right, Diana, thank you so much. Thank you, Josephine. Greetings, everyone. It's exciting to be here, and thank you for joining us for this important webinar. As we all know, achieving quality in healthcare is on the global agenda. If you look at these reports and resources on your screen, they all emphasize the point that if you are to achieve universal health coverage, then it's important that we build quality into it upfront. For what is the essence of increasing access to healthcare, even the end, quality is not part of it. In that case, we will only be increasing access to poor or suboptimal care. And so quality is important when it comes to quality of healthcare on the global scale. And we know that it will not just happen. For a healthcare system that we know that are functional or that are effectively functioning, I will have to do so based on hard work. And so we know that with gradual steps, we all get there, particularly for us in low middle income countries. Let's go slide next, please. Okay, so let's look at the context of quality care in Ghana. Achieving quality care is a stated priority of the Ghana Ministry of Health. If you look at these documents that you see on your screen, they recognize the importance that the government of Ghana attaches to pursuing the quality vision. We have the National Healthcare Quality Strategy 2017 to 2021, which has elapsed, and I know that is currently under review. Then we have the National Healthcare Policy 2020, and then we have the Ghana's Roadmap for Attaining Universal Health Coverage 2020 to 2030. These are all documents that contain our quality objectives when it comes to healthcare. And so you can take a look at these documents within the Ministry of Health. Now, if you look at the National Healthcare Quality Strategy, there is a nice definition for quality in healthcare, but it's a long one. But essentially, it says that quality in healthcare means that interventions should be in accordance with standards, as well as including these components that you see on your right side of the screen. Now, these 7 items you see are what we call the dimensions or components of quality in healthcare. And back in the early 2000s, the Institute of Medicine, the now Academy of Medicine in the United States, came out with these components, and it has guided global organizations such as WHO. Recently, WHO added the integration components, so we have 7 of them here. So when we are talking about quality, we are talking about these things. Safety, which means that care should minimize harm, including preventable injuries and medical errors. In other words, people should not come to the hospital and go home being harmed. That is a quality issue. Effectiveness is about care that is based on scientific knowledge and evidence-based guidelines. So care should be informed by the best available evidence of what works, and not just on routine or the way we have always done things. So that is effectiveness. Patient-centeredness is about care that respects and responds to patient preferences, needs, and their values. Timeliness says that care that keeps delays in providing and receiving services to a minimum. Equity is saying that care that individuals receive should not vary based on because they are male or female, based on their age, based on their ethnicity or geographic location. Integration, as I said, was recently added by the WHO and says that care received across facilities and across providers should be well coordinated. And efficiency says that we should avoid waste of resources, including equipment, medicines, energy, and even ideas. So these are important to think about when we think about quality. What comprise quality is about these 7 dimensions. And I think it's important for us as clinicians because knowing these things helps me in terms of my own individual practice, how I'm contributing to quality by engaging in these things. All right, the next slide, please. Okay, so now that we know what we mean by quality, or now that we have clarified what we mean by quality, I know you'll agree with me that there are great opportunities for improvement in Ghana when it comes to quality of healthcare. And so we as nurses, nurse leaders, nurse educators are well positioned to contribute to the quality vision by engaging in these approaches for improving quality care. And so we have evidence-based practice, quality improvement, and research initiatives. These are what we collectively call forms of nursing inquiry or inquiry for my US colleagues. You know, so Prof. Baptiste will be taking us through these forms in just a moment, help us to understand and appreciate their similarities and distinct differences or futures. But I want to end, I want to end this slide by saying that as nurses, we need the knowledge and skills to be able to do these things. But also important, we need the resources, access to resources, and the leadership support to be able to implement EBP and QI initiatives to improve healthcare quality. Thank you. Next to you, Dr. Baptiste.
Thank you, Stephen. Thank you. So as Stephen mentioned, nursing inquiry, there are 3 approaches involved. And so I want to talk about what we're going to do moving forward is actually help you differentiate between the 3 approaches, because at times these approaches are, typically these terms are used interchangeably, especially in clinical settings. So we want to clarify the differences between the 3 and help you understand that all 3 of these approaches are underneath the umbrella of nursing inquiry, but they seem very much alike, but they're quite distinctive differences. So what I want to continue saying is that nurses do have the opportunity to identify gaps in healthcare, and that is the part of what we do in order to facilitate nursing inquiry. Within nursing inquiry, whichever approach you choose, the goal is to explore some unknown territories. However, but in research is where you want to generate new knowledge, and we're going to speak a bit more about that. But also, nurses also play an integral role in developing and updating clinical practice guidelines. And again, through EBP and research and QI, we can actually update policies and procedures. But most importantly, it is important that we choose and use the most appropriate type of nursing inquiry as we improve practice and improve patient outcomes. So with EBP, QI, and research, they all pretty much do the same thing. We can actually use all 3 approaches to translate research into clinical practice. It's just different models that we use in order to implement these particular projects. However, it's really important to understand that as you are choosing your type of nursing inquiry, it's really important to develop teams to address the clinical problem. Nurses should never really work alone in addressing clinical problems. It's really important that we gather with others who have some type of clinical expertise or clinical experience to help us understand these approaches. Important is that we have to understand that our goal in implementing these changes in practice settings are there not only to improve patient outcomes, but to reduce morbidity and mortality. So, whether you are leading a very small EBP, QI research project or large, your end goal should be a very broad goal into reducing morbidity and mortality within the population that you are serving. And more so, as Stephen mentioned earlier, he talked about dissemination, and we're going to talk a little bit more about that later on into this presentation. But as we choose whichever approach that we are going to use, we want to also have the goal of contributing to global improvement in patient care. So we don't want to just leave it right there within the hospital. We want to make meaningful changes that can be disseminated more widely beyond our own clinical settings. So which one will you choose? EBP, QI, research? It doesn't matter. Whichever you determine is right for you. However, what I want you to know is nurses are uniquely qualified to implement all types of nursing inquiry, of course, with the most appropriate training and guidance and leadership. And our focus should always be patient-centered. Whether we are working with nurses or with other healthcare professionals, the patient should always be our common interest when we're choosing some type of nursing inquiry. It's really important that we use nursing inquiry to promote interprofessional collaborations and also to cultivate a culture of nursing scholarship or inquiry, which Stephen's going to talk a little bit more about as he goes into his discussion of EBP specifically. And again, really important that we are not just making changes that are meaningful to our institutions, but also contributing to the science of that particular topic. So why do we do what we do? So we do what we do because patient care. So again, each approach can be very different, and we're going to go through each individual approach to help you understand how these approaches are used. However, the end goal is the same, patient care. So all EBP QI research is patient-centered. You really should be keeping the patient in mind as you develop these questions or identify these problems. And I just want to give you a little bit quick background on nursing inquiry. Nursing inquiry is really not a new concept. Dating back to the early 19th century, Florence Nightingale pioneered nursing research through data collection, making an inference to poor living conditions, right? And so she really identified through data collection, how she can improve patient care during the Crimean War. But more so that was a very early model. And then in the 1960s, we started developing more quality improvement models using the Adombire framework, which came out in the 1960s, and it provided a more systematic approach for activities leading to measurable outcomes. In the past, EBP QI research was really conducted by physicians and not so much nurses. So even though the approaches to these inquiry into scientific inquiry goes back and has some historical context, it's really quite new in the context of nursing, where nurses have just started really implementing these types of nursing inquiries somewhere around the 1990s. And again, depending on where you are geographically, this could also be a very new concept, across different parts of the globe. So what's the difference? Here's a quick model, a snapshot, just to help you understand the difference, because again, these terms are often used interchangeably in clinical settings. However, they're quite different in their purpose, the goals, and the process for each. So in EBP, the goal is really to access and use the new knowledge that you have synthesized from the evidence. In QI, the approach is to improve processes within clinical systems more on a system-wide level. Again, also keeping the patient in mind, whereas research is a little bit more involved, because research challenges us to generate new knowledge and to contribute to creating new knowledge and contributing to what is not previously known. The processes for all three are quite different. The EBP process is very much focused on problem solving involving clinicians. And using the literature, appraising the literature to solve these clinical problems. Whereas QI, it's really about testing an existing process and using a rapid cycle framework to collect data, test the process, and present meaningful results. And then again, research, it's really the process is about making your results generalizable and transferable to a larger population. So impact of EBP and QI is very wide. We can use QI and EBP to change policy and protocols. As we know, the nursing care that you provide in your clinical settings are always based on policies and protocols, and we use EBP to update those protocols or to change those policies, just finding the best practices or using the best possible evidence to guide what we do. Also, we use EBP and QI to influence education, improve patient outcomes, meet organizational goals. We also use it for continuing education and, again, dissemination on a local, national, or international audience. And more so, another benefit of EBP and QI for nurses professionally is that nurses who lead EBP and QI projects can benefit from some career advancement. So over to you, Stephen.
All right, Dr. Baptiste, thanks so much for taking us through or highlighting the similarities and differences between these forms of nursing inquiry. So we want to jump in and focus on evidence-based practice, EBP for short. And as you can see on the screen, the way EBP in nursing is conceptualized as a three-legged stool. And so when you take one aspect away, it doesn't quite fit or it wouldn't stand. You need to have these three components of best research evidence, the patient preferences and values, and the clinician expertise to be able to have EBP. And so putting these three components together, we see the definition of EBP in nursing, one of the definitions being that a problem-solving approach to clinical practice that integrates the conscientious use of current best evidence alongside the patient preferences and values and the expertise of the clinician. So essentially, EBP is saying that in terms of care, when making decisions about patient care, individual patient care, the decision has to be informed by considering these three aspects. What does the research evidence say? And then what does your expertise and as a clinician, what does it tell you? Maybe based on your assessment of the patient, based on knowledge of what you know, but also incorporating the values and preferences of the patient. So including the patient and the decision-making is critical. And I'm sure, I mean, who wouldn't want this or who wouldn't like this form of care? Because obviously this contrasts with healthcare decisions that are based on, routine practice, the way we always do things, or the way this is how we do it here. which necessarily does not take into consideration the best evidence. So we want to be in a situation where we are doing what we do because this is what the best guidelines are saying, this is what the best evidence are saying, as opposed to this is how we have always done it, or this is how I saw someone do it, this is how I saw the manager do it, and that's why I'm also doing it. All right, so let's get to the next slide, please. And so in thinking about how EBP might look like, in practice, the use of EBP frameworks or models can help us to have a sense or understand how that might look like. There are a number of EBP models. I'm sure you may have heard of them. Johns Hopkins evidence-based practice model is one of them. You may have heard of the Iowa model. You may have heard of the 5-star knowledge translation model. You may have heard of the Ottawa research knowledge tool and all that. But we've just focused on 3 here that we want to mention. And the first is the Johns Hopkins evidence-based practice models that came up in somewhere in 2007. And it says that it starts by noting that there's a problem, and that's where the inquiry comes in, that there's a problem to solve. And so once you identify that, the next thing is now to create a question. And usually when it comes to creating the questions, there are templates or a mnemonic that guides us in doing that. The whole idea is to be able to convert a clinical problem to a question that will allow you to search database. So you have to develop your practice question, which we will later highlight. And then once you develop your practice questions, you need to search for the evidence. So you go to the relevant databases. It could be Medline, it could be PubMed, it could be CINAHL, it could be, ERIC, it could be PsycInfo, and search. And once we search that, you will get the relevant articles, primary studies, synthesis, best practice guidelines. And then what we need to do is to critically appraise these, synthesize the evidence. And then once we now have the evidence, this is what the evidence say, we have to determine whether there's a gap in terms of what the best practices are telling us and what we do in our ward or in our hospital. And so that is the best practice. The best practice are the best practice recommendations or what the evidence is saying. And so once there's a gap, we need to put that into practice and then, evaluate our practice and see whether we have achieved the outcome we intended. Please, the next slide. So this is the JBI model. I wouldn't go into this much, but it's also a model that recognizes that when it comes to implementing evidence, so the aspect of implementation comes in here, and then it's helping us to appreciate that in terms of EBP, we need to follow these through. There's a need for mobilizing knowledge. You not first have to identify that there's a knowledge need. You have to contact the research, and then based on the expertise as well. And then we have all those. So the external component that we have here. Then you have the issues of the FAAN. So it should be feasible, it should be appropriate, it should be meaningful and effective. So healthcare intervention should be all that. So evidence generation here is talking about you searching the database for the evidence and then synthesizing that. Then once you have the evidence, you transfer it to practice and then you implement and then to improve global health. Yeah, so basically that's what this is telling us. Can we go to the next slide, please? Now, this is the ACT model, which is advancing research and clinical practice through close collaboration. This model is different from the other 2 models. The other 2 models are what we call process models, in that they guide teams or they guide you as to how to be able to do an EBP project. But this model is this ACT model is a system-wide model. It talks about how do we build an EBP place. So we have a hospital. We want to build a culture of EBP. How do we go about doing that? And so this is your model to go to. It says that essentially that to start EBP initiatives in an organizational or system-wide level, we need to first assess the organizational culture and readiness for EBP. And there are tools to do that. And once we do that, we identify the strength and measure barriers. So maybe you may identify the strength that, already management is committed to improving EBP. Already we have EBP mission and philosophy in our hospital vision and mission statement, so these are strengths. But we may also uncover barriers such as clinicians do not have the knowledge and the skill to be able to do that, or we do not have EBP mentors or champion, So once we identify that, then we go ahead to address this by developing and using EBP mentors. So these will be clinicians who have been trained and skilled in the EBP process, but also have knowledge about organizational and individual change management strategies. And once we have these in the clinical side, they can help to support the implementation of EBP. And once EBP implementation goes up, we expect that health outcomes will go up. All right, let's go to the next slide, please. All right, so EBP steps. Essentially, what we have said when it comes to EBP, these are the steps. Typically, we have the traditional 5 steps for EBP. Step 1 says that when we want to undertake an EBP project, we need to identify our question. And we have PICO as a mnemonic that guides us how to structure the question well. And the question will help us to now search the databases. So it says, ask the PICO question. And that means that your question should have the elements of the population of interest, the intervention you are interested in, what is the comparison, and what is the outcome. And in some situations, time may be an optional component to include. And then once we have clearly stated our question and identified those facets that we have for the PICO, we need to now search for the best evidence, search the relevant databases. Is it Medline I should go? Is it online? Is it ERIC? Is it Psych Info? Is it CINAHL that I should go? And once we go there, we search, we will find articles, primary studies. We have synthesis, systematic reviews, guidelines, which we now need to critically appraise them and then synthesize the evidence to tell us the totality of the evidence. And once we have that, we integrate that evidence into practice by including our clinical expertise and then the patient values and preferences in making the decision, then evaluating the outcomes of the practice change. Okay, so these are the traditional 5 steps. Please go click the next slide. These are the traditional 5 steps. Then Melnick and colleague tells us that, the next slide again, Melnick and colleague says that why stop at 5 steps? Why don't we add 2 additional steps? So step 0 and step 6. So we have step 0. So Prof. Melnick and colleagues says that we should also consider cultivating a spirit of inquiry and EBP culture in our organizations or healthcare facilities. And that means that we should have this questioning attitude in our practice. So with the aim of improving care, we should be questioning. I wonder if putting the patient in an upright position helps prevent aspiration pneumonia compared to the patient lying down, or why is it that we did it this way? Why is it that this is how we do it? I mean, we want to have that culture where we are constantly asking ourselves questions for the purpose of improving. And the EBP culture means that we should have the necessary resources, we should have leadership support, we should have access to internet, we should have the databases to access, we should have access to the guidelines and all that. We should focus on building that. And when you have these in the organization, then we can expect that EBP implementation will go up. And when we do that too, so the final step is the step 6, which is to disseminate. So this is about publication. When we do a practice change, let's report, let's write about it, publish it. It could be even be a local health of unit meeting, or even at a DEBA, or even at meeting the hospital where we say that, oh, May Surgical Ward, we undertook this EBP project. This is the outcome, and but we can also publish it on international journals. And I know if people are interested in that stage, Prof. Baptiste is one of the editors of a relevant journal as we head. So these provide opportunity for us. All right, so I think that, okay, so this is an example of a practice question using a PICO, in case you're wondering what that might look like. So we have PICO standing for population intervention comparison and where required time aspect. So example of a PICO question will be in patients with hepatitis B, where hepatitis B is the population here. How does acetaminophen compare to ibuprofen? So acetaminophen is the intervention. The comparison is ibuprofen affect liver function. So our outcomes are what? Liver functions of interest. So you may need to do some lab tests to see the liver enzymes and how they have been affected and all that. So this is an example that has a clear facet of those elements that we've mentioned about. The time aspect, of course, is optional. Maybe you're interested in up to 6 months. If people have taken these 2 drugs up to 6 months, what is the outcome? So this is, once we have this question well structured, then we will use these key terms into our databases. So is the hepatitis B that you enter, or viral hepatitis, or then acetaminophen or paracetamol, they come to ibuprofen, or we enter that into the databases. Let me say that what we have just looked at in terms of the steps, what this is also telling us that there are certain knowledge and skills to be developed. That to be able to do EBP, you need knowledge, but you also need skills. And that is where competency-based education comes in when it comes to that. competency-based education is saying that what do you need to know in order to be able to do EBP? And so there are certain skills that you need to know, skills to frame your question, skills to search the databases, skills to critically appraise your various research studies. If it is a systematic review, how do I critically appraise it? If it is an observational study, how do I appraise it? If a descriptive study, if it's a best practice guideline, how do I appraise it? So all these are suggestions that skills are needed to be developed, which of course is beyond the scope of this one-day webinar. Thank you. Okay, so let's go to the next slide, please. So I think Dr. Baptiste, want to take this one?
Yes, thank you, Stephen. Thank you for that wonderful discussion on evidence-based practice. I'm going to go into a brief discussion about quality improvement, which I will refer to as QI as an abbreviated way. So quality improvement really is, again, I talked about how we use quality improvement to where we work with teams in tandem with leadership. So leadership typically will have a very heavy involvement in quality improvement. And what we do within these teams is that we develop a systematic approach to improving patient outcomes. And I'm going to talk to you just briefly and show you some examples of those systematic approaches. So here's one, the QI process, also very much like EBP, it involves many steps. So this is a 6-step process to quality improvement. And so when we're looking at a quality improvement, we typically will use a rapid cycle approach. Within this approach, as Stephen talked about in his about EBP, he talked about development and cultivating a culture of nursing inquiry. And that is also necessary in the clinical setting in order to successfully implement a quality improvement project. So when you're looking at a QI project, you want to ensure that the culture within your institution establishes quality within in every practice. So with that being said, the leadership within your in your institution should be very much concerned with improving quality in order to even begin a quality improvement project, because as you begin a quality improvement project, it does require time and resources and sometimes money. The wonderful thing about quality improvement is that typically it's more cost effective. It's not as costly as research. So this is why we really like to choose this approach in clinical settings where resources and money is typically a little bit more sparse than in research institutions. So step 1, you want to have that culture that establishes quality in practice. And then in step 2, you want to determine and prioritize areas for potential improvement. So for example, an example of a quality improvement project that I implemented at the Johns Hopkins Hospital was that we found that nurses in the emergency department were at the highest out of any other ward within the hospital with medication errors. So we really and that is a patient safety problem. So we wanted to implement a quality improvement project that would improve the process of administering medications, and so that the outcome would be that we had less medication errors and less risk and harm for our patients. So with that being said, we prioritized the area, step 2, then we collected data. So the data that you want to look at when you're doing a QI project is just to get some baseline data to see what is happening within that patient population. You're looking at how many medication errors or how much harm has been done as a result or reported as a result of these medication errors. So your data collection, you always want to look at preliminary data. And then as you implement your quality improvement intervention, you want to collect that data after the intervention. So typically when you look at quality improvement, they typically will be pre and post test, where we look at preliminary data and then compare it to the data after we've implemented the new process or the new intervention. After you've completed your intervention, you want to communicate with your acquaintances about the results. So again, this is the team working in tandem. You want to evaluate the results and see how you can use these results to improve processes. And then you want to have a commitment to continuous evaluation. The biggest goal in quality improvement projects is that they should be, if your results are meaningful and you make a meaningful change, you want that meaningful change to be sustainable. We don't want to just implement a quality improvement change for 3 to 6 months. We want to implement it where we're always evaluating it and always improving it. So it's very cyclic in that fashion. And then we want to expand our successes. So the example of the medication error quality improvement project that I led in the Johns Hopkins Emergency Department, when we saw that this improvement project worked well and we did reduce risk for medication errors and we reduced medication errors, so we took the show on the road. After that, we recognized that it was working well. And so we implemented across all 6 hospitals within the Johns Hopkins Health System. And so that's what I really urge you to do with your quality improvement, not to just leave it within one center. If you have multiple centers in your region that you believe that these results and this process improvement could influence a good change, then you want to implement that change across health systems or across regions and hopefully globally. And so that's the goal. One of the processes for quality improvement, we typically guide our QI projects using a rapid cycle framework. And the most popular framework that you'll see in the literature for quality improvement is the Plan, Do, Study, Act, or also known as PDSA. So Plan, Do, Study, Act gives you just 4 very basic steps to quality improvement. And so typically the first step is to plan. So, think about, you meet with your team and you think about what are you going to do? You identify the clinical problem through EBP, and then through evidence-based practice, and then you identify what is needed to improve these particular processes or to promote patient safety or positive patient outcomes. And then in the do stage, this is when you actually implement the plan, right? Because by now you've already had your preliminary data, you've already considered what is not working well, and now you're going to implement and test what you've gotten from the literature to see how well it works within your institution or on your patient population. And then study is when you analyze your results and you study, and you have to debrief with your team and see what has gone well, what hasn't. And those components within your quality improvement project that has gone well, that's the part that you want to use to improve processes and make changes based on these findings. Now, for example, sometimes there are parts of the quality improvement project that has not gone well, and that's okay. As long as you keep working on that, you keep reevaluating it, and you keep looking for strategies to improve that part of the process. As long as no one is harmed, then it's perfectly fine. So again, quality improvement projects actually typically are, the risk for harm is extremely low. It's done in a rapid cycle, typically somewhere between 3 to 6 months time. And so it's really a good way to learn how to implement, how to change processes in a very safe space with a team that is well-trained. So let's go, we're gonna move on into research, because research is the biggest topic. Research is between the 3 types of nursing inquiry, research is the most complex of them all. And so I'm going to spend some time with just really providing you with a very basic background of how nurses use research to improve clinical outcomes. So research, I just want to remind you, is a quest for generating new knowledge. When we're doing research, we are contributing to something new to the science. So we're addressing what is not known or addressing gaps within the evidence-based literature. My advice is that research should always be conducted under the supervision of a PhD-prepared researcher. And this is because research is so complex. There are many frameworks, models, conceptual models, and many approaches that could possibly increase the risk for harm. So with that being said, someone who is trained in research as a PhD-prepared researcher will know all of these rules. They will know all of these particular parameters into understanding how to conduct not just rigorous research and meaningful research, but also safe and ethical research. Because again, remember, as the patient is the center of our research, we want to make sure that we are safe and that our patients are safe throughout. Research is typically completed in 1 year or more. Sometimes, as you can see, research can be completed over 3 to 5 years, sometimes 10 or 20 years if it's a clinical trial. So there's many types of research approaches, and we'll talk about that in later slides. But again, it's really about studying something that's not previously defined by science and generating some new knowledge that can be used to improve patient care. Typically, so how do we know what is not known? It's very difficult for us to determine, especially as novice researchers, it's very difficult to determine what is not known. are ready, because we all have great and wonderful ideas, but sometimes we recognize that our wonderful idea has already been taken. Someone has already facilitated research within on that particular topic. So it's really important that we always begin with a literature review. So as you do, and you want to consider whether you want to do a systematic or integrated review, whichever one you choose, you're going to be using a very systematic approach to synthesizing and appraising the literature. And so as you do a literature review, as Stephen had mentioned, you can search several databases: Medline, PubMed, Scopus, Web of Science. We also have some very nursing-focused databases like Embase and CINAHL. And so again, if you're working with a PhD prepared person, they will know these databases and they will help you identify which ones are appropriate. More so, if you ever have access to a medical librarian, they also are very well trained in understanding library databases. And so, you know, should you have access to those resources, I would encourage you to use that. So as you do your literature review, you will identify gaps in the literature, and the gaps just meaning like, you know, what are the opportunities for further investigation? It's really important when you read an article, in the conclusion of the article, there's typically a part where the author will say further investigation is warranted or further research is needed in this particular area. And that really helps us identify what is not known. And if we look at our literature review and we see that our research question or hypothesis that we have formulated has not yet been answered, then that's how you can guide your research project. Another good thing about a literature review for me is that it really helps me identify theoretical frameworks. Research should always be done using some type of guide for not just reporting your results, but also how you approach your research and your patient population. So theoretical frameworks really help us guide those steps. And sometimes when you read these studies, you can find some really good theoretical frameworks that will be applicable to your research question or hypothesis that you have. And I just want to clarify, there is a big difference. So Stephen talked about the practice question. The practice question does ask, using the PICO format, you know, it's really just targeting the clinical problem, you know, looking at the population and, you know, trying to identify the best practice and intervention and comparing these interventions. Whereas when you're doing research, you will be formulating a research question, which typically could be just looking at relationships to see if one particular intervention improves a patient outcome, or it could be a hypothesis where you want to prove an association or, you know, or prove that this particular intervention that you're proposing from the literature will work or will create a particular outcome. So again, as you look at the literature, sometimes when you look at research studies, sometimes they use a hypothesis and sometimes they use a research question or both. So I just want to help you understand the difference. And that is just the starting point of how we identify gaps in the literature and guide our research projects. So again, review of literature is a very important part. I just want to walk you through the steps of a review of literature. Typically, we identify the question or the hypothesis. We review discipline styles. That just means that sometimes you want to think about what type of literature do you want to study? Are you going to only keep it narrowed down to nursing literature, you know, like nurse-led interventions, or are you going to look at possibly medicine or social sciences? So that's something you could determine with your team. You want to search the literature using the databases that we talked about. We also have to manage your references, because depending on the literature review that you are doing, you probably will get a large amount of studies. And so reference management systems are very important. I think it's really important to use like a managing software like Mendeley, Covidence, or RefWorks, or whatever your institution may have, or you may have to purchase. Hopefully it's feasible. But managing references manually can be very difficult, especially if you're managing hundreds of papers. Then the next step is to critically analyze, and there's a lot of tools that you can use. So none of this is common knowledge. None of this is expected to just do off the top of your head. Every single step of research is guided by a framework, a checklist, or a guideline. And as you get familiar with those, and you will learn how to use those to guide your research. So going back to JBI, the Joanna Briggs Institute, they actually have free resources where you can actually access these tools to help with your literature review. And also the Equator Network, which I also have the link in a few slides ahead. that also provides free resources. So much of this that you are learning as you are working in research, you can have these resources at no cost. As you synthesize the literature, that's how you synthesize your results, and then you write your literature review. When you write your literature review, we strongly encourage you to get that published, and that's going to be the preliminary summary that's going to inform your actual larger research study. As you guide your research, it's important to understand research ethics, and especially when we're working with human subjects, it's important that we write our proposal and send it to the institutional board review. It could be at your university or at your hospital or at your healthcare center. Most of them do have an ethics review. If they don't, typically you can find an ethics board within your region or possibly through a health ministry that can help you use these guidelines so that to ensure that you are using the most ethical approach and reducing any risk or harm to the patients that are involved in your research. So when do we need IRB? IRB stands for Institutional Review Board, or the Ethics Review Board, as many places refer to. Typically, you can use it really for all types of nursing inquiry. Definitely for research, it's very strict that you must always have ethics review. For evidence-based practice, not so much, but again, it's really good to actually propose an ethics application, and then they will let you know if it's exempt or not. And once it's exempt, then you can move forward with the project. And then with QI, same as EBP. It's always good to write your application and get approval, whether even if it's exempt or it's an expedited review, at least you have that documented, because anytime that you want to publish your results, if you've made this wonderful change, we really want you to publish your results. However, when you publish your results cannot be for research and QI cannot be published unless you have proof and a statement that you have obtained ethics approval. So just to let you know, I love this slide because I always say, in God we trust. We all trust God and we follow God for everything. But as nurse scientists and doing nursing inquiry, everyone else must have data. And so the data collection is very important. Whether you're looking at EBP, QI, or research, it's quite important that your data makes sense and that it is reflective of the inference that you are making in research. So it's really important to understand, and again, working with a PhD prepared researcher will help you recognize how to not only collect the data, but to do an accurate analysis of data and reporting of that data. So many research methods, there are two types that are very, that you'll see commonly, quantitative and qualitative research. Quantitative research refers to as a structured way of collecting and analyzing data. It's very numerical. It's typically looking to measure extent and looking for statistical results, interpret objectively, whereas qualitative research is more of the use of words. It's a very naturalistic inquiry that seeks in-depth understanding of a social phenomena. So for example, if I do a qualitative research project, I'm really just looking at numbers, right? So I could be looking at just doing a descriptive analysis, looking at a prevalence of a disease amongst the population, or looking at relationships between and looking for these significant results. Whereas qualitative data, I'm looking more for like the experience of the patient. So it's a little bit more personal, where you can use focus group discussions or semi-structured interviews to find themes. So for example, qualitative research is used very commonly in oncology or cancer research, where researchers would typically sit with patients who have experienced cancer and ask them about their experience and their feelings. So depending on which one you prefer, both are very meaningful, especially if you're researching something that is not known and you're producing a new results. Both of them can be used very meaningfully in a clinical setting to make practice changes and to create new policies for usual care. For quantitative research, we commonly use software to analyze our data because, like I said, it's very numerical. So sometimes we use software. Some people have used R or Stata or SPSS. And then whereas in qualitative data, you can, even though if you're using more words and sentences and quotes from from the actual participants or patients, that could also be added to a software called In Vivo or Max QDA, where they can actually help organize themes of that research. So for example, if you are interviewing someone who is, let's say you're interviewing a caregiver and you want to know what their feelings are about death and dying of their loved one, sometimes the software can help you pick up themes within what they're saying. Like, so a theme could be sadness, a theme could be fear, a theme could be anger or concern. So that's how researchers use both types of quantitative and qualitative research. Okay, so these are common quantitative designs that you will see as you're looking through the literature. There's a lot of descriptive designs, which include case reports, case series, and descriptive surveys. And so epidemiology studies really are the basis of a lot of the studies, because we cannot do research without epidemiology. And epidemiology really just helps us understand as clinicians, what is the prevalence or the incidence of disease, whether you're studying HIV, AIDS, gynecological cancers, or cardiovascular disease. The epidemiology studies are a good starting point, because it helps you understand not just the background of the disease, but the significance. And the significance of disease will include the morbidity, the mortality, and also the disease burden, which is often commonly reported in these epidemiology studies. So that creates that foundation for research. And then there are observational studies, cross-sectional studies designs help you look at relationships. So for example, in my research, I look at relationships between poverty and education and cardiovascular disease. And so I see how one variable impacts the other. So let's say poverty and unemployment will impact, higher rates of cardiovascular disease amongst different groups. And then, and then there's experimental research, which you might see nurses involved in more like lab trials and field trials. And especially with the emergence of COVID-19, nurses are getting more and more involved in, they were involved in the vaccine development and also, studies of clinical trials for different new drugs. So again, there's so many ways that we can, do research, whether we choose quantitative or qualitative. Nurses are definitely positioned to work within these teams and and also nurses, as you know, get PhDs so that they can actually lead these teams. I won't spend much time on this, but I just wanted to show you this visual of the research process. This research process is over just 12 months, just 1 year. But like I said, it depends on the topic. It depends on the approach of the research. It can be, 1 year is possibly the minimum, because most research projects that you will see, that you will read in the literature or that you might be involved in, will last for 2 to 3 to 5 or more years, depending on, the actual protocol. What I also want to say about research is sometimes research can be expensive. It's not as cost effective as evidence-based practice and quality improvement. With research, because it requires so many resources and so much time, typically researchers will seek out funding from organizations, whether it's from charity foundations or actual government organizations that can fund research. So it's really important that as you choose research, that you will learn under your training how to write these proposals and grants so that you can get funding, money to fund your research. So that's another part of what we do. So as I said, nothing in research is done on our own. We use checklists. So just to remind you, as you begin your research, you should always do a systematic or integrated review of literature to ensure that you are choosing a topic or a question that's going to generate something new, some new contribution to the science. You want to always choose the appropriate design to answer your question, right? Because we talked about those designs, whether you're going to use quantitative or qualitative, and sometimes people choose both. When you see a mixed method study in the literature, it's because they're using both the quantitative research, where they're looking for more descriptive and numerical data. And then you'll see the qualitative piece in a mixed method study, where they're actually looking for the naturalistic inquiry, where they're looking for thematic or content within the subjects or the participants that are involved. So always important to use correct units, methods, and statistics. Statistics is very important because, like I said, in God we trust. However, all others must have data. So your data has to make sense. We also have to ensure that we have followed our IRB protocol and guidelines for ethics, for ethical research. And then I always say, have a statistician check your work. As nurses, we're not expected to be expert statisticians, whether we are research trained or not. So it's really important that we do employ the services or add someone who's really good with statistics or trained in statistics on your team to ensure that you're reporting. And also following reporting guidelines. So I put the link here for the Equator Network. The Equator Network has an abundance of reporting guidelines that researchers use, but we won't go through that, but please, look at that on your own. So teamwork, I talked about teams, right? No nurse should be doing research, EBP, or QI on their own. They really should be working within teams. Rarely do we ever see nurses or any healthcare professional engage in inquiry activities alone. Typically, the projects are carried out in collaborative teams. Nurses can work across disciplines to address very important patient problems. Your team does not have to be all nurses. It can be, however, but I personally like to work across different teams because sometimes working with a physician or someone who another healthcare professional like a physiotherapist or a nurse practitioner, they can bring some expertise into your research project and make it rigorous and meaningful. So these are 3 types of teams that we work with: multidisciplinary, meaning working across disciplines, employing expert input from healthcare professionals, but still working in isolation just within that team. Interdisciplinary means professional teams working collaboratively. So not so much in a small group, but across. And transdisciplinary is now kind of a new term that we're using. And really it's a diverse team that can include members from various healthcare disciplines, but also inviting non-healthcare personnel like community members, caregivers, and support. And one of the things that we do a lot at Johns Hopkins is our work. We actually invite the clergy. We invite pastors of churches, community members, community leaders to ensure that, and we employ their expertise within our research projects to ensure that we're developing and designing the right interventions to help their communities. So really interesting that pastors now are very much involved in research, which is a wonderful, wonderful change that I am really excited about. So Stephen talked about dissemination of the work, and I just want to go through that very briefly. So what is successful dissemination? As we mentioned, any of this work, no matter what type of nursing inquiry you design, you should have your work disseminated widely. So you want to first have it presented as a poster or podium presentation at a local, national, or international conference, because you want to share it with a broader scientific community. You want publication in a scientific or nursing journal. So if your research or EBP or QI project is very nursing focused, there are several nursing journals that are peer reviewed where you can submit your work. But dissemination is not just about publication on paper. Many journals have gone online to save paper, to save money. And what happens is your work can still be widely accessed online because many nurse researchers and clinicians are actually going through these databases and pulling and downloading articles from online databases. But really, at the end of the day, you want to get the information to the right people in the way that they can use. And an example of that is that we had done a project at Hopkins, and it was a very small EBP project, and we didn't think it was so grand, but we presented it at the Sigma Theta Tau conference one year, which is an international nursing conference. And a nurse who attended our poster presentation was very intrigued by the work we did. And she actually was a nurse leader in Jamaica. And so she later emailed us a few months later and told us that she was so inspired by our project and she was so really excited about implementing it in her hospital. And so our project actually, because we disseminated it at an international conference, we actually know that it was replicated in Jamaica at a hospital. So that's the impact that we want to have. And that's just one small impact. There's so much more that we can do, but that's just a small example. But again, dissemination is important because you want to introduce yourself to a greater clinical and academic community. You want to test out ideas and perspectives, because each time you present, sometimes your audience will give you feedback and they'll help you enhance your project, or sometimes they give you, ideas to generate a new research question from what you have presented. So there's always some good productive conversations, intellectual conversations that you can get through disseminating. And it really helps you also foster a national or global presence for yourself and your institution, which also really helps to improve patient outcomes, because what you're doing within your region or within your clinical setting, when you present it, it can be disseminated globally. So I just want to leave you with that. So back to Stephen. Thank you.
Thank you so much. Thank you, Dr. Baptiste, for the amazing presentation so far. I couldn't wait to get to this slide because all that talk is good, right? But how do we begin to foster EBP in Ghana? I know that I'm in Canada now, at school in the UK, and in all that experiences, I realized that starting with, you have these, what we call national imperatives for EBP. So there are system level documents, policies that require that clinicians in practice and those in academia should engage in EBP, quality improvement, other areas like interprofessional education and working in teams and all that. So you have these system level expectations that have been set. And so when you have things like that in the system, what happens is that schools or nursing academic institutions begin to ask ourselves, how do we ensure that by the time our students come out to practice as nurses, they have the competencies to engage in EBP? Those are the hospital levels. Managers, leaders will ask, how do we ensure that we are supporting our nurses to be able to provide EBP, right? So how do you foster EBP? We suggest that one of the key things is to look at the policy issues, policy framework, where all accountable stakeholders need to come. It is when all accountable stakeholders, Ministry of Health, Ghana Health Service, professional nursing associations, and other organizations come together to work that the aim of EBP can be accomplished. So we need to have this in place, starting with. I think at most now, if you have gone through the Nursing and Midwifery Strategic Plan and Services Framework, which I know some of you may be familiar with, they make this statement that there's a low culture of nursing and midwifery in Ghana, and identified EBP as one of the cross-cutting or essential factors needed to address if you are to improve the quality of nursing and midwifery. At least it's good that we have that policy document recognizing that. And so the question for us is, how do we move on from there? How do we begin to build that aspect of EBP into our healthcare system? And then under the policy framework, we can also talk about making it a requirement for EBP in academia and clinic settings, as I've said. And so I'm here, if you take, for example, standards to entry practice that have been designed by various nurse organizations, Canada, UK, and all that. When we take that document, one of the things you see is that nurses, by the time they are going to practice, should be able to engage in evidence-based practice or evidence-informed practice and all that. So it means that nurses need to know that before they enter into the practice field. So these are just the system level things that we need to consider first. But particularly within the field of education, in terms of using EBP education to advance EBP in nursing, we want to consider integrating EBP education into the curriculum. And so it was not until I started doing my master's in the UK at King's that I was introduced to a subject or a model called evidence-based decision-making. From all my educational experiences in Ghana, I have not been introduced to something like that. So we need to integrate EBP content into the curriculum. We should have courses that are called evidence-based practice, where we are teaching students how to develop the competencies required to be able to engage in evidence-based practice at a field. Of course, faculty preparation is important. Faculty need to be supported. So they need to develop the self-efficacy for EBP. We need to have academics or nurse tutors, nurse educators who have the knowledge of EBP and can teach and model it for students to also follow. And then through programs like this, where we have CPD or immersion workshops, immersion workshops are like, you can have a 5-day immersion workshop where we come together. This is an EBP day. The focus is to educate us, to help us gain the skills so that when we go back to our organizations, we can go and support EBP implementation. Then development of EBP mentors and champions. These are people who have been educated, or in addition to having the organizational and individual change ideas to be able to lead EBP. And then the final one, next slide, please, is that access to resources. So access to resources. So we are talking about, if we are in the clinical field, we should have access to best practice guidelines. If I need to know what the best practices in wound management are, probably do you have a national database where I can go to, where we have, compiled the best practices as to what to do when it comes to wound management, Electronic databases. I'm sure most of our institutions in Ghana, apart from the academic ones, we are going to have problem accessing these electronic databases because of paywalls and all that. But I know some like Cochrane, may have access to it. But other databases, how do we search or how do we have access to them? Computers and internet access in our hospitals, these resources like JBI and Equita Network, as we mentioned earlier, the EBP mentors are. So all this, and then having protected time, leadership support. So protected time, that means that when people are given the time to work on an EBP project, they should be given the time as part of what they come to work and do, if people are working on that. I know a facility where it's a teaching hospital in Ghana where the nurse manager has set up a research committee. And I see this as a unique opportunity. If we can focus on EBP, for these individuals or this committee to focus on developing themselves for EBP and supporting EBP implementation in their organizations. Leadership support, a very important factor when it comes to sustaining EBP. If we have leadership support in organizations for EBP, it is from research, one of the key drivers of ensuring that EBP will be implemented. Nurses may have the knowledge and skills, but if there's no leadership support for it, we can't. So we also need to recognize that we need to celebrate it, like the little EBP projects that we have, that we develop. We should be able to recognize people for it, reward it for individuals for that. I know currently in Ghana, there has been a lot on quality improvement. And I know that in most of our hospitals, we have quality improvement teams. This is a facilitator or a strength that we can leverage to see how do we also bring about EBP on board, because the assumption under QI is that it's about process improvement. But the underlying assumption is that you should have, whatever you are trying to improve, you should have the best practice already. All right, otherwise, if you're improving the process and the practice in itself is wrong, then you are only improving a bad practice, right? So we talk about quality, evidence-based quality improvement. So for QI to come in, we ask ourselves, what are the best practices before? And once we see that these are the best practices, but the process has not been leveraged, then QI can come in at this point. All right. So I think that this is great. I think just to offer suggestions for us to begin to consider as we think about, how we can advance EBP in Ghana. Next slide, please.
Yes.
Okay. I think our time is fast spent. So Lana, let's quickly rush up about this and then, we move to discussion.
Thank you, Stephen. So as we're going to be bringing this program to a close, we want to be respectful of time. So I just wanted to know that nurses do have the responsibility to contribute to the science and improve best practices and patient outcomes. So just some things to ponder on and think about. How will you get there? How does nursing research improve your career? And also, how does the research impact the patients, your facility, and care systems in which you work? And what is your contribution to science? So just some questions to ponder. But as we close out, I just have some take-home messages. I want to say that all nurses are uniquely qualified to improve quality of care. Nurses are well positioned to improve quality of care through nursing inquiry. And nurses also need to advocate for support because, again, as Stephen mentioned, protected time, resources, all those are barriers. And those are barriers in what I believe in low and middle income countries, but even so much in high income countries, just like the US, Canada, and UK. So even though they have the resources, sometimes they don't have the time and the leadership support to implement these programs. So we're all, there's different struggles in different places that we need to consider. So, and another take-home message I want to just leave you with is that nurses in Ghana can effectively apply concepts of EBP, QI, and research to improve patient outcomes. We want to empower you. We want you to know that you are capable and that you are qualified to do this. And this is something that we hope that you will take in consideration and contribute to the science and also to protect and to enhance the patient care that we provide. Again, Stephen talked about the use of educational resources to help. Many are free. We did put some links to the ones that are free that you can look and see, but the Joanna Briggs Institute, I believe, JBI, offers a plethora of resources that you will find helpful at no cost. But at the end of the day, Stephen and I want to encourage you to lead, present, and publish. Please do follow those steps, and that will just help us as nurses really not only contribute to this science, but to empower ourselves, improve our profession, and to protect and to improve the care that we provide for our patients. So I think we can go into Q&A now. We might probably have about maybe 15 minutes for Q&A. Here are some questions to ponder for yourself. But Stephen and I are happy to take any questions that you might have regarding this presentation. Okay, so I guess we can go to the chat, Stephen, and then start looking for questions here. I also want to just show you our references for today that we had used to develop this presentation. And also we will share these slides for our attendees, and this is our contact information. If you have any questions after this session for Stephen and I, we are available via email. And if you are on Twitter, we encourage you to follow us on Twitter, and also follow the GDNA LinkedIn page for updates and other webinars, upcoming webinars, and also the Twitter handle for GDNA is here for your use as well. So now I just wanted to do that, and then we'll go to questions.
Yes, so I think we were looking in the chat, but if people have raised their hands, I'm sure one of the executive members are on the general page and can help us know if people have raised their hands so that we hear from them.
So I see a question from Roger. It says, how do you synthesize literature? Yeah, Roger, very good question. So synthesizing the literature, as you could complete your literature review through your databases, we usually typically add what we call inclusion-exclusion criteria to narrow down our search. And so when you narrow down your search, you might only choose articles in English only, articles that are published in peer-reviewed papers, or human studies, because possibly we're not going to use animal studies. So sometimes that narrows it down. Once we have narrowed down our literature, the synthesizing of literature, typically we use, I use the Johns Hopkins evidence-based practice tool, which provides a table. And within that table, it helps me organize what's in the literature. So typically the columns of the table will be, first is the author and the year that it was published, the setting, right? Because you want to say, okay, is the setting, multi-center, one-center, hospital versus community, and then also the key findings. So really, synthesizing literature is really just trying to analyze the key findings and recognizing what you can take from the key findings. So when you do that, you can actually use tools. Like I said, nothing that we do is done just based on, brain power. We'll use tools and guidelines, and the tools will actually provide you with actual steps. And there's a lot of critical appraisal tools that you can find on the Equator Network for to synthesize literature. One of them is the Prisma. Another is Grade, or Grade and stuff. So again, with the Johns Hopkins EBP, also JBI has some tools that you can use to help you synthesize the literature. So really, it's just about separating what you're getting out of it. Your key findings, your setting, your sample, and also looking at the limitations and the gaps. And once you identify those gaps, that is how you synthesize.
Yeah, so Roger, create a synthesis or a summary table, and where you extract your key information. And when you do that, so you have authors, you have publication date, maybe findings, key findings. In the end, you see a pattern emerge. And once we create these synthesis or summarized tables, and then it tells you what is the pattern that you are seeing. All right, Dr. Angela, A appears, hand is up. May we hear from you, Angela?
Yes, thank you. So thank you for this wonderful overview. I noticed one thing you did not mention through the process is something critical that I believe some of us who are trying to do the interdisciplinary approach to research are trying to figure out. What is the IRB process in Ghana?
Yeah, a quick comment on that. So it depends on your research or the institutions that are involved. So I, for instance, recently submitted my application for ethics. And because my study is focusing on nurses in the district, regional, and teaching hospitals, multiple IRBs were involved. So for the district and the teaching hospitals, they are under the Ghana Health Service. So I had to apply to the Ghana Health Service Research Ethics Committee. Now the teaching hospitals have their internal IRBs as well. So I had to apply to the teaching hospitals involved. And so some of them require, I mean, the Ghana Health Service one, the process is there. You get in touch with the administrator, provide you the resources you need and how it should be organized. The same for the teaching hospitals as well. So I realized that for one of them, someone needed to be there in person to check and then pay the money, but they also have online payment systems as well. So in brief, I think, yeah, as far as healthcare is research, I mean, sometimes there are others like the Nambrungu Health Research Institute, you know, and other ones, but it all based on your topic as well. And that can guide you in determining which are the appropriate review boards to contact. I hope that helps with your query.
Yeah, I mean, I knew it. I just wanted to, so the audience understand that there is an IRB process. I have had people say to me, they are getting IRB from the United States and they go to Ghana to do research and they're stopped. So I believe it's important that people know that there is an IRB process in place in Ghana that they have to go through, especially if they're doing an intercollaborative research, QI or EBP. Just wanted to add that.
Great. Thank you so much. Please, further questions, contributions. You can use the questions we posted. Diana, please maybe be on that slide. If someone wants to comment on the suggested questions for discussion that we have on the slide, but you also have your own question that you want to ask, please feel free to do so. Yeah.
Yes. And I want to thank Dr. Commodore Mensah. She added the link to the Ghana IRB ethics research management site for those who are interested. It's in the chat. And there are also some other resources that have been posted in the chat. So I encourage everyone. So there's another answer. There's another question. Okay. Oh, sorry. It's a comment. So Nishta says that the barriers in her area is a shortage of staff. Yeah, Stephen, do you want to
Yes. So is this a Ghana hospital, I suppose? Yes. Inadequate staffing is one of the barriers generally to EB implementation. You know, the issue about not having sufficient staff will mean that, you know, we get to be stretched and we are busy and all that. And so it is one of the things that we need to look at, address if we want to ensure that we are implementing EBP. Yeah, so that is important. Inadequate staffing as a barrier to EBP. And some of these things falls within system level initiatives that should be taken to address that. Yeah, we know how in Ghana, it's not the individual hospital that necessarily recruit nurses, but it's from the national level where nurses are posted. Yeah, so we are looking at it, and that's why we think that in our efforts to advance EBP, we need not just to focus on the clinicians, but we need to focus on the national, the system level issues as well. Yeah, all right.
All right, and Sandra's asking for to locate the link for the test.
Yes.
Yeah.
Yeah, so I think we can copy the test. This is a post-evaluation survey. We will copy it and put in the chat. Yes. In fact, we were supposed to have a pre-test, but once we're not able to do that, it's still valid to answer these questions because these are the same questions for the pre-test are for the post-test, but we have included evaluation of this presentation for your feedback on as well. Yeah, thanks so much.
Thank you. Yes, it's been posted to the chat. Thank you, Dr. Commodore Mensah. Okay, yes, please. So someone asked, Felix, thank you for your question. Please, what's the full meaning of IRB? Yeah, so IRB is something, and I can give a little bit of history background. IRB is, it means Institutional Review Board. In some countries, they don't use that term. That's more Western. but in some countries you'll hear it as ethics board or ethics review board. So what happens is the ethics review board is based on the Helsinki Declaration, which came about in Eastern Europe after the World War II. What happened during World War II is that there was a lot of unethical research happening all across the world, actually, because in the past, researchers just did research. They, they did pretty terrible things to people who were poor. For example, in Scotland, anatomical researchers, as they were developing anatomy textbooks, they would research, people who were poor or peasants on the street who had died. They would just take their bodies and cut them open. So we are not allowed to do that anymore. So Helsinki Declaration, what it does is it provides ethical principles that must be followed in order to protect to protect the research subjects and make sure that we are approaching their research in an honest and a respectful way. So based on the Helsinki Declaration, since that time, all around the globe, every medical institution that is doing research must have ethics board review. So you're going to hear it as IRB. We're going to take maybe one other question, and then Dr. Commodore has to do, would like to share some other information from you. So I see there's a few questions here. Barbara, thank you for your question. Barbara says, we here in Ghana also have a habit of not completing a research project, or someone takes over and finishes it to his or her benefits. My goodness. So Stephen, would you like to speak to that?
Yeah, well, I think it's more of a comment. Yes. We can leave it as it is. That's the observation that Barbara has made. Yeah.
Absolutely. Yeah. Thank you, Barbara, for sharing that information. And that is unfortunate because, we really would like research to be completed and and with ethical approaches and with a well-defined, principal investigator or authorship. So I'm sad to hear that, but I feel like that happens a lot of places around the world as well. So I don't know that it's unique to Ghana, unfortunately. There's a question from Serena. She says, are you aware of any grants available to fund EBP and quality improvement projects in Ghana to promote EBP in nursing? That's a great question, Serena. Stephen.
Yeah. I don't know the answer to this one in terms of, I know that when it comes to funding research, I know there may be limited opportunities. And so I'm not sure whether we currently have some of these things to fund EBP, but I'm sure there are alternative ways to go around it. I mean, as we mentioned, relatively speaking, EBP and KI are less costly compared to, a research project. And so if it's something that we are doing within the institution, and we get the buy-in from management, and this is something that is a priority topic, I'm sure IGF, internally generated funds, may be used, but we can look beyond that to see other international organizations that may be interested. Maybe if you are a member of Sigma, for example, or just the International Nursing Society, they fund small grant and some of these things. Yeah.
Yeah, absolutely. I agree. Sigma is a good resource because it's international, and they do provide small grants to fund EBP and smaller scale projects, as well as larger scale research projects as well. So at this point, we will conclude this Q&A session. And as I said, we're always available via email for questions, and I'm going to hand it over to Dr. Commodore Mensah, our president.
Okay, thank you so much. First, I'd like to thank our experts today, Dr. Diana Baptiste and Mr. Stephen Adombire, for sharing your expertise with us. We know it took time for you to put this together, so we really appreciate this effort. And I know a lot of our attendees have learned a lot from today's webinar, so thank you so much. So for all our attendees, thank you also for making time to attend. We would like all of you to get involved in GDNA. If you're not a member yet, please visit our website. Membership is free. And there are opportunities for you to join committees, to even lead a webinar like this. So we know that there are experts on the call who can present webinars on different topics. And this is only one of many upcoming webinars on research, QI, and EBP. So consider this as an intro to research, QI, and EBP. So if you do have expertise to share, please engage with us. Someone mentioned grants, right? There are grant writing opportunities so that we can support the education of nurses and faculty in Ghana. And on social media, Josephine posted the links to our social media platforms in the chat. Thank you again, Josephine. Please engage with us. Next slide. So upcoming events, just to put this on your radar. So there are other webinars we are holding. We actually have one that's coming up next week, and you'll hear about it shortly. We will have a conference in the US in Baltimore, October 28th, and you'll hear more in the coming dates. So please mark your calendars. And we are planning to have a conference in Ghana this December or early January of 2024. So again, please mark your calendars for a conference in Ghana, and we are planning outreach events as well. Next slide. So like I said, we do have an upcoming webinar next week. So many of you may have joined our webinar on the migration of nurses, where we heard from experts who had a lot to say about the causes, the ethical considerations when it comes to migration. And in the feedback, we heard that people wanted to hear from nurses who've actually made that journey and migrated to different countries. So we listened, and we have organized part 2 of this webinar. And so you'll hear from people, nurses who have migrated to the UK, Canada, the US, and they have a lot to share. So please take time to register for the webinar, and we'll put the link in the chat for you to register, but it's going to be next week on the 7th. Next slide. And you've seen this in the chat. Like I said, please stay connected, follow us on social media. We want to hear from you, so please take time to complete the post-test, but there's also an evaluation at the bottom. We want to learn how to do better as we continue to develop these offerings. We encourage and welcome any constructive feedback, feedback on the presentations, ways that we can make the information more accessible. Many of you have asked for copies of the slides. Our amazing presenters have agreed to share a PDF version of the slides. So we will send the slides via email when we also send a link to the recording of this webinar. So please stay tuned. We'll send this information via email. And if you have any questions, please reach out. You can reach us at info@gdna.org. And if you visit our website, all of these links are also available. And I believe this is the last slide. So with that, I'd like to close things and just say thank you, everyone. Our goal was to really finish by 1:30 today and make sure we are respectful of everyone's time. And I think we accomplished that. Thank you all so much, and let's stay in touch.
Thank you. Thank you, everyone. Thank you, Dr. Commodore Mensah. It's been an honor. Thank you.
Thank you.
Thank you, everyone.